I'm the next speaker. Well, we have a wonderful. Okay, can we have this on? We have a wonderful talk today. So we talk about insurance coverage. We talk about these guidelines and recommendations. I think as a group, we have obligations to do in several key important factors. We have to engage parents and the families in the development of virtual realities, engagement, and we have to disseminate. Somehow I cannot see this here. So we disseminate and implement this into clinics and communities. We have to push the insurance company to allow the reimbursement, and also very important as a scientist, we have to build the scientific evidence so other established scientific discipline can view us as a reputable trust field. Today, so what I will talk is about the key features of pediatric pain elevation therapeutics. I want to show you the age and sex difference and the potential underlying neural mechanisms. So, yeah. Next, please. Okay, how do I?
The green triangle.
Okay. Okay, that's a short video of our research. Today I will show the main result of RCT among 6 to 7 years old BEM patient treated at an outpatient clinic. I also will show our result. The paper published by Megan Armstrong here about using our VR at home. And finally, my focus is on the key features of virtual realities. We all talk about virtual realities, but what are the key features actually impact the pain elevation therapeutics? So we did a study among burn patients 6 to 17 years old at our burn clinic. This is a randomized control trial. What this one is different than other researchers is we have this active VR is the intervention, and we have this control called passive VR, which is they watch the exactly same VR content, but without interactions with the VR. Active VR, they actually play with the VR. The second control group is standard care. Why this is important? Yesterday, there's a talk about you have to be careful in terms of choose your control in your study. So this study is very unique. We have this active VR, passive VR, and the standard care. At each group, we have 30 cases. And this one shows the patient basic characteristic and their expectations. You can say there's no significant difference between those three groups. So in a way, they're very comparable. However, you can see our result prove our hypothesis active VR when you actually have interactions with the VR is the most effective ways to help the child to reduce their pain. And this is a patient-reported feasibilities. You can see those kids basically said this is a very good. They like it very much, and the parents liked it very much. And we also asked the clinicians to report acceptance and how easy this can be integrated into the clinical practice. And they all thought this is easy to integrate into the clinical practice. Actually, so when you develop your VR and you have to involve them, involve the physicians and engage the nurses to see how this can be integrated into clinics. Our study shows our VR can be easily integrated into the VR practice, clinical practice. The second study is an important study. We did this among those children who need routine home dressing changes after they are discharged from the hospitals, which is important because after a lot of these pediatric patients, after they are discharged from hospital, they still have these needs. One of these is a little bit different than other studies over there. So you can see we have this repeated measurement. We have this dressing 1, dressing 2, dressing 3, dressing 4, dressing 5. If the effectiveness of VR decreases, right, which means the effectiveness will not be as good at the beginnings when kids got so used to the VR. This has implications for other VRs if you are designing like virtual reality for chronic pain, design virtual reality for rehabilitations. Repeat measurement is very important. Another important thing is actually there's a significant statistic challenges here. Analyze the repeat measurement of pain medication, and of other things together present a challenge for the statistical analysis. So I will not have time to talk about that, but I challenge all of those people in this room to think about in the future when you evaluate effectiveness or efficacy of your studies, think about the repeated measurement. Plus on that, there's important factors there. Pain scores are actually influenced by the pain medication use because pain medication use can reduce their pain. And then while you evaluate the effectiveness of VR, how you consider repeated measurement, pain medication, and pain scores. That's another study design and the statistic challenges there. Our study shows that children report the experience at home. Actually, you can see in terms of VR realism, VR engagement, happiness, and VR fun, they maintain that higher level of engagement, happiness, and realism, which means the effectiveness of this will not decrease. This is a child and parent reported overall pain and the worst pain score. You have to use statistical method to compare those two groups. So we used a concept called area under curve. It's not just the simple comparison, but it's area under curve. So you can see the change in terms of area under curve, we can achieve like 33%. That usually is considered another important factor in our studies, clinical meaningful effect. Clinical meaningful effect is very important. You can see some differences, but is the effect clinical meaningful versus statistically meaningful? Statistically meaningful, usually, I'm a statistician, usually we use, oh, I'm so excited, my p-value is less than 0.005, right? We're so excited about that. But clinicians and nurses and doctors and physicians and the families, they were asked a question, whether your results are clinical meaningful or not. So I strongly encourage everybody in this room to think about in the future to focus on that. Okay, an interesting question is, virtual reality has been shown to be effective in alleviating pain for pediatric patients during a variety of medical procedures. However, whether the effectiveness VR for pain alleviation differ by patient age and sex. Particularly, we talk about age, different age groups, 6 to 7 years old, 9 to 14 and 14, but also by sex, whether female and males, or boys and girls, which group they will have the more effect. Okay. We reanalyze the data. We are so lucky we have asked all these questions. But when we published our first paper, we have not realized that. And then later on, after we got more research and more insight about research, we realized we have the data connected from our original study. So we want to assess whether age and sex impact how our VR pain alleviation affect the pain during the pediatric burn dressing changes. Second aim is evaluate whether different perception of the VR, game realism, fun engaging correlate with pain alleviation. One key data analysis is this path analysis to assess the interrelationship among the VR key features and their impact on self-reported scores by age and sex. Path analysis is a special analysis methodology to trying to evaluate this. Here's our result. We already said this. We have this age and sex we want to evaluate, but first we need to compare, active VR and passive VR. In our original study, we have 3 groups. We have active VR, passive VR, and then standard care. But this study focused on key features of VR, so we exclude that standard care because they do not use VR. In terms of these, burn injuries, in terms of their TBSA and severities, and there's no differences among all these groups. Our result here you can see actually overall pain, we found out actually younger children, they are significantly more likely to report higher score of pains. In terms of VR expectations, no difference. But however, you can see here, VR expectancy by ages. Younger children are more excited. They have a higher expectation of VR will help them. There's a significant difference. We are fun, no difference. We are engagement, no difference. So here's our result. These slides show all of the complicated correlations having VR fun, engaging, and sex variables, and then time thinking about pain during the procedure is based on the traditional VR distraction theory. If 75% of your attention are still focused on the pain during the procedure, that's different than 25% of pain are still focused on the pain, and the majority of my attention is on the game, enjoying the game. That's sort of a distraction theory that was based on the 1965 Science article. But you can see here, okay, time think about pain is acting as an intermediate factors. And we have this VR fun and we have engaging. VR fun and engaging are influence each others. If only the distraction theory works, then engaging will not be the significant factor. If only, let me repeat that again. If only distraction is the mechanism, engaging and other factors will not be significant, right? However, you can say, after even considered time thinking about pain, engaging is still a significant factors. And then we also look at the age as a factor. And then here we look at the direct and indirect factors and the total effect here. You can see we are engaging and total syncope pain during the brain dressing changes are still significant factors. If we look at the age, fun, and engaging time syncope, all of these actually are significant factors. So based on our studies, we suggest there's a potential new VR pain alleviation mechanism, which, in addition to the distractions, there may be some mechanism in the pain processing in your brains. Actually, VR can affect. So that will help those children to reduce their pain. In summary, VR was similarly fun, engaging, and realistic across age and sex, but less effective in alleviating pain in older children. VR engagement and time thinking about pain during brain dressing had a significant direct positive effect on self-reported pain, suggesting an anesthetic mechanism beyond distraction alone. Future development and research of VR innovation therapeutics should include key features that could significantly impact VR pain innovation effectiveness. So there are so many VR out there, but a lot of them have not gone through all this thorough evaluation in terms of pediatric appropriateness and key features of their mechanisms, and a lot of them has, I would say, have not gone through these rigorous randomized control trials. So I encourage all of us to work together to promote rigorous science in our field, and then to actually promote these exciting new technologies in the medical field and also in other social domains. So I have to acknowledge we have so many collaborators on our studies. I just show some of them here. And also I want to thank the funding agencies to support our research. Thank you. Okay, question? Okay. Yeah, maybe Jeff's group has done that, right?
Yeah, I mean, I think what I was mentioning earlier is that we covary some of the patients who aren't receiving narcotics, for example. So we use that as a strong covariate to see, because I think VR is not replacing narcotics as much as it's a companion, right? And so we often look at baseline, premorbid, major before we look at intervention. I think he's done a beautiful job of starting to dissect what are some of the other ingredients that are contributing to efficacy or outcome. The active, passive is a wonderful breakdown. Looking at premorbid variables is a great breakdown. Looking at comorbid narcotics is really good. All these things. And then ultimately getting to a profile of a child, not just by age and gender or sex, but also by behavioral issues, cognitive functioning. There's all these other premorbid variables that are relevant to really create that robust profile of who's a responder, who benefits, and things like that. So I think different groups are working in different ways, but they're complementary. I think we're doing some studies right now also looking at passive active. It's really important. Are you just watching a movie or are you actually engaging? I use the word immersive a lot. I think uses the word engaging, but I think they're synonymous. So I think that's what we're starting to deconstruct. Does that answer the question?
Yeah, it did. Because I'm, taking care of patients who frequently end up on narcotics.
Yes.
Tolerance. And so I'm beginning to wonder if maybe at some point we may begin to notice tolerance with immersive therapies, just as we do with narcotics.
And I think I'll just say one other thing, Henry.
Yeah.
Some groups are working towards home care kits, right? So like you see Cedars did that with Apply and for Relieve RX, where they learn how to do it in the hospital. It goes home with them when they're having sort of breakthrough pain. They can PRN for meds or for the relief. You know what I'm saying? The VR homes kit. So it's sort of we need to have it leave the hospital, right, and get into the home for whatever that. And for wound care,
Yeah.
Henry was talking about the same thing. And that's where you really start to get some traction. It's not just experimental in the institution anymore, it's actually in home. And so I think that could also chip away a little bit at that concern around addiction or opioid overuse or misuse or whatever you want to call it.
Okay, quick question here.
Yes, I was really interested by what you said about passive active, and I was interested in how those two are sort of, where is the defining line between them? And also
Between...
passive and active.
okay.
And then also sort of in terms of what, I just wanted to clarify, so what you said about it being, so even if they don't find it fun and engaging because it's distraction, there is still the potential, because it reduces pain and they're not thinking about pain, fun and engaging doesn't matter as a metric?
No. Okay, to answer that key question, so is thinking about pain is the distraction, right? But however, engaging also is very important, maybe more important. Okay, so we have to move on.